Hello everyone, my name is Dan Gestico and welcome to When Tomorrow Comes. This is Iceni's regular look at the world of planning, development and placemaking. I'm Dan Gestico, I'm Iceni's Director of Futures, and this week we're going to be talking about healthy places and healthy placemaking. I'm fortunate enough to be joined by one of my Iceni colleagues, Gill Eaton. How are you doing, Gill?
I'm good, thanks, Dan.
Great, nice to have you. And we've also lucky enough to have Josh Artus from Centric Lab. How are you, Josh?
All good, Dan. Yourself?
Yeah, very well, thanks. I'm glad to have you on board. So, as is traditional with these things, we're going to hand over to Gill now, who's going to give you a bit of a summary about the email we sent out recently on the subject of healthy places and healthy placemaking. Over to you, Gill.
Great, thanks, Dan. So the topic for today, for this week's blog, was very much about how the planning system and the NHS evolved at the same time to address health issues, and how both systems have progressed, very much going off in separate tangents, and how it's a really interesting time at the moment, given the health crisis is very much a time of reform in the planning system, and how it's a really good opportunity to look at how we can do things better. At the same time, we're seeing a massive data and technological progress in terms of information available to planning and to decision makers. And how can we look to amalgamate and benefit, look for the win-wins of all these situations happening at the same time, and especially when it comes to placemaking. It's very much an area that Iceni are involved in through a number of different specialisms. So we're very involved in engagement, in impact assessment, in sustainability, as well as futures. So it's looking at this issue through those range of lenses almost, and seeing how the planning system can evolve to improve health outcomes for people, as it's such a critical issue for us all.
Okay, brilliant. Well, that sounds like a fascinating basis for this afternoon's discussion. Josh, do you want to give us a bit of background about the work you've done previously for Centric Lab and how this relates to healthy places and health and well-being?
Yeah, sure. So we set up Centric Lab in 2017. We're a neuroscience lab dedicated to creating solutions to elevate public health. We work with private, public and third sector organizations to help improve places, policies and work on special projects to advocate for better health. Really, our job is to also try and break down the barriers between citizens and authorities and the companies that act in between. And so one of our jobs is organizing, for example, the Urban Health Council, which is an initiative that we have set up, which Iceni are part of. And the purpose here is, as a cross-disciplinary organization, how do we create an effective language that it's stemmed from neuroscience research and anti-racism principles, that we can have a very equitable and clear, concise language about what is health, what is urban health, that's rooted in solid science, that then all parties can have a good conversation, understand where we go forward. So Centric is dedicated to improving health outcomes wherever it may be. We do this through the use of science, applying good research and building data tools to help people make better decisions. So we've worked with developers out there, we've worked with different NGOs, as well as working directly with community groups. I think everyone wants to see better health outcomes, and what we see is no one's really talking on the same page. So that's one of the jobs that we try to do at Centric.
Okay, and do you think that Gill's right in saying that now represents a sort of golden opportunity to relink health and well-being and placemaking?
Yeah, the weird, perverse nature of the pandemic is it brought people's attention to their local environments and its impacts on their health. People sat at home a lot more and understood how much noise was coming through the windows when the window was open. And they started to realize, actually, once they fled the leafy suburbs and into the center, when they go back to the suburbs during the day, they started to realize, well, this is what it's like for everyone else who's still walking around during the day. So I think we've had a good awakening on our relationship with the local environment. I think one of the crucial elements we have to address is climate change. And I say that not from as this totalitarian, scary element, but it does pose challenges to urbanization and continued living in urban environments, everything from even mild increases in heat through to flooding, but also there are broader questions around what does it do to the flora and fauna of certain regions. And so we do have to start addressing this if we're going to have resilience in our local areas, and that we're going to have healthy people, healthy families growing up, pregnant people who can have healthy children as well. We're starting to understand the impacts of health on unborn children, also the environments on unborn children. So it's crucial that we start thinking about, well, what will life be like in 2050, and start working back and going, what are the tools that we need to make sure that we're going to be able to build a resilient society through the built environment, not just by changing people's behaviors. So I think now's a golden opportunity. We're all making our 2050 carbon net zero pledges, etc. But what does that actually mean for an elderly grandparent to try and walk to the shops when the rain is thundering down? Does that mean they stay indoors? We already have a loneliness crisis and elderly crisis in this way. So it's better to start thinking about really building a lot of empathy into decision making in the urban environment.
Okay.
Yeah, and it's topics that we're very much seeing in discussions that are happening elsewhere. So I've been part of the Health and Wellbeing in Planning Network, where that's bringing together health professionals with planning professionals, because we can't possibly fix everybody. Everyone needs to take ownership of their own health and improve their own health outcomes. So it's interesting how the NHS and health professionals are looking to the planning system to see, well, what can it do to bed in sensible, healthy day-to-day habits to reduce the overall cost on the NHS, which can never be met in its totality.
Yeah, and are the NHS offering up practical examples that we can use in our work?
There's definitely work being done. I know the RTPI have done a number of case studies of examples, and we've got the NHS Helping New Towns initiative. So there's much more being done on this, and especially, as Josh was saying about data analysis, how that can start to be pulled into decision making. And this is, I think, going to be so much more of the forefront of decision making going forward, is having the stats and data to back up the outcomes for different options available to us.
Can I make a comment just against the NHS and the planning system? I think what's quite interesting, and something where I think some of the mistakes where I have discovered where the mistakes have been made in the past, is that health is very much seen on an independent level. And I think you're right. Try and have the ability to eat well and try and exercise is very important. However, what epidemiologists have been saying for decades and decades and decades is that there are broader social determinants of health. And slowly but surely, factors such as air pollution, for example, one we all talk about, are starting to come in as a more of a environmental determinant of health. And then, so part of Centric's work is to look beyond the person and also look at the place and start to go, well, hang on, if we understand that air pollution can be a determinant of health, what about noise pollution? Because our bodies react to stimuli like that, as well as factors like heat stress that can come forward, as well as being exposed to artificial light for sustained periods of time. And so we'll get to this a little bit later, I think, on using data analysis, but in the same way that it is good to have good behaviors, we also have to have a good system in place. And this is the responsibility of urban planning, is to not dictate the types of behaviors that people can have. It's to help better regulate and provide a healthy environment so that people aren't dwelling in environments that by their sheer default are causing a biological reaction, putting their health at risk. So I think it's really important that in particular, the urban planning organizations and departments start to work better with clinical commissioning groups and other organizations for the NHS to understand, let's not address whether someone is going to be healthy in this area. Let's start addressing how healthy this area based on the levels of air pollution and noise pollution. And we can start to think, well, this is an urbanism or urbanization problem because they come from activity. And urban planning is arguably the management of activity that goes on in certain areas. So how do we better regulate and organize and mitigate our own activities to reduce the levels of risk and exposure to citizens before we start to go, well, let's make sure that everyone is doing the right thing. And I think that's the difference between a top-down and a bottom-up view, or really it's taking a very ecological view to health. And I think it's amazing that, this is just to reference, sorry, her name is dropped right out. Rosamund Adukisi Deborah, whose daughter Ella passed away, and with the coroner, the third cause saying from air pollution. At no point was the GP ever asking where are you living, or ever assessing, I understand there's asthma, but what about the air pollution? And there's this break, and there's this complete break that GPs, and I'm not trying to pick on them, but it's a cultural thing that we don't address the place and a person that is inhabited when there is decades and decades of research, from the weathering hypothesis coming out from the United States of America in the early 1990s, talking about the disproportionate ill health effects to African American women from the experiences of structural racism, including impoverished environments, all the way to people like Robert Sapolsky talking about poverty and deprivation as a pathway to stress and what that means for further health outcomes. We kind of know all of this. And so I think a big challenge is actually having the humility and the empathy to start joining the dots and understand urban planning is healthcare.
Yeah,
but we have regulations
yeah.
relating to pollution. We have regulations relating to air, to noise, to heat stress, and we have recommendations about light pollution. Gill, are these not sufficient?
Well, I was just going to say, it's the need to look holistically. So often in this country, if you've got a heart problem, you see a heart specialist. If you've got a diet problem, you see a dietitian. But but we're a whole being, aren't we? We need to look holistically. And the same approach applies to the examples you just given. We do consider specific elements, but there's a need to just kind of zoom up and be like, hang on, what's happening on the whole impact on the person, stroke the place, stroke the environment, not just pick out these individual elements, I think.
I guess there is a compounded effect of all of these things. So how do we move forward? How can we use greater amounts of data and digitisation to help us design better places? Because, it's never the intention of a design team to result in poor health outcomes. No one ever sets out with that design objective. How do we kind of use all this data to actually implement change and design better places? How do we learn from what we know?
Yeah, I think I've got two ways I can kind of answer that. I think the first, on a pure data basis, it's not just to plug what we're doing, but what Centric is really concerned with, as I said before, is understanding how the broader environment and the habitats in which people dwell and live result in health. And we've got a great data science or geoscience partner called CGG. They're a French organization that have been working with us to expand a tool that we developed for London. So we used a lot of open data from the London data store and some satellite data to look at these factors. And we brought all the environmental data together, put it in a GIS model, and developed our own scales according to the research that we've done through the scientific research. And it kind of gave us almost like an MRI for a city, running through and going, oh, wow, there's an anomaly here. This is an exceedingly high area. There's a problem here. We should address this. So they've helped us scan this out for the entirety of the UK, or sorry, I should say England, Scotland and Wales, because of the availability of the data, that we can start to now make a decision and evaluate change based on an area's current baseline. And so if we know an area is high on certain factors, that any further change is going to be either pushing an area into a dangerous level. So I think there's one side of that we can start to build tools to question areas more effectively and understand our risk assessments and method statements against these areas more effectively. I would say, Dan, I agree with you. A lot of research is already aware of the impacts of things like noise and light on our health. However, I'd also say that they favor the change rather than the person who may be exposed to them. And something we have to also understand about health is that it's not about a mere input-output process. It's something about an experience over time. And so I think this is part of where the second part of the conversation comes in, is when it comes to data, we sometimes fall foul of trying to get loads of data to almost either correct or confuse or change an existing community or a person's experience, and saying, look, it's really noisy here, or I think I'm getting headaches from the local area. And I think there's a big job in planning and really improving things like community engagement. And I know your colleague Kieran is director of engagement, something he leads really well and something he really critiques very well. And it's I think having better channels to listen to the voices of communities, because arguably they're the people that have been living there for 15, 20 years. In many cases, they're the ones that know and have been able to see what's happened when change comes through. And I think it's really important that we listen effectively in that way, because when we start listening differently, when we start applying also an intersectional approach to people and communities, and I think this is one of the key failings of the health impact assessments, is that it treats everyone that we have one common baseline. And so if air pollution exists, then it's like, oh, well, okay, there's a bit of air pollution, maybe there's a marginal increase. But if you are unfortunate to have a pre-existing health condition, or the fact that you already lead a life that has high levels of innate stress, I'm not talking about stress of like, oh, my life is difficult, but structural stress from working shift hours to insecurity of housing, insecurity of employment, being exposed to harsh chemicals, etc., that cause biological stress, even that marginal increase in air pollution, alongside a sense of hopelessness that you can't change anything, that once it happens, they start digging up the roads and they start building a development right behind your home. That sense of hopelessness is also another added stress. All of a sudden, we're weighing people down. And so we don't actually have any community sensitivity to the changes that we make. And so how do we address the susceptibility of change to different community groups? How do we understand what's going on so that what we do, we don't lead to the inequities? We're not all on the same average baseline. And I think that's one of the good changes that can come from the planning system, better understanding communities. And part of that is data. I think part of that is using digital tools to listen more effectively.
Yeah, and equipping planners with the skills to be able to take on board this analysis. So for me, I always use the comparison with the heritage sector, maybe 15, 20 years ago, that we just, the planning system wasn't as set up to have very comparable analysis on different heritage assets. So you'd get a listed building over here with a 50-page report going into insane levels of detail compared to buildings being demolished in conservation areas that probably shouldn't have been. Whereas we've got a language, we've got policies, we've got a narrative, we've got developers getting on board early doors with the right specialisms, and we've got in-house experts being able to inform planning decision making. So it's whether that comparison could come through to health, so that we have health professionals commenting on planning applications to a proportionate degree, whether we can have the right level of input. So committee members and planners are taking on board appropriate levels of health consultee responses to then feed into the system. And whether health should be one of the key objectives of the NPPF, to me, it is shouting out to be a central objective of the NPPF along with the existing three.
Well, can I comment on that? Because there is no definition of health in the NPPF. No, I appreciate that a broader policy framework shouldn't have a definition of everything, but it is the problem with lacking a definition in places like that is it allows for interpretation. And interpretation can be weighted by bias or prejudice, or by good intention without adequate resources. And it's in those places that and this is where we feel, and it's one of the recommendations in our report, that if we start to define health through a biological and a systemic way, we all start reading off the same hymn sheet. Because whilst planning, etc., works often by political boundaries, whether it be wards, local authorities, or wherever, people don't live by those boundaries. People live across multiple areas. And so how do we be a little bit more dynamic in our interpretations of health, and not just, well, people in this little borough, I'm going to make sure they're healthy in the following way, and the people next door, they have their own version. Yeah, everyone's moving in between. So I think, the NPPF should start looking at definitions of health, but those based on, I'd say biological principles that are anti-racist and anti-classist, because health can be prejudicial. We have had eugenics in the past to define a lot of, for example, Britain and forth. So I think there is a clear example where the built environment, whether it be the developers, the construction organizations, the planners, start to actually advocate, can we please start to define these things better in our planning frameworks? Because you know what, we're getting crapped on by people because we can't deliver, but we have to work within the planning frameworks. So I think there's a big job on the planning sector also calling themselves out and trying to build up and advocate for better policies to govern them, because arguably it does come down to the strength of the policy that people respond to.
Right. Well, look, if ever there was a call to arms across the industry, then you've just heard it here. That's pretty much all we've got time for today. I'd like to thank both our guests today. Gill, thank you very much for your contributions. It's brilliant having you along as ever.
Thanks, Dan.
And thank you very much to Josh from Centric Lab. Brilliant having you on board, Josh. Hope to catch up with you again soon.
Absolute pleasure. Thanks, Dan, and thanks, Gill.
Thanks everyone for listening.
Great.
Bye-bye.
Thank you. Bye.